Okay, thank you, Mr. Chairman, dear colleagues. I was asked by Dr. Sinderbø to talk about NAVA in preterm infants with bronchopulmonary dysplasia, but I responded that I have no expertise on that topic. We focus on lung protection and prevention, and we have succeeded quite well, and we have very few patients with bronchopulmonary dysplasia. So this is the title we agreed on. I will focus on NAVA use in earlier phases of care of preterm infants. I will show our practice and show it using patient examples, and hope it is of help for you and stimulate new ideas of research. We need to keep it clear in our mind what is the goal of our treatment. We need to make the choices in the care of preterm infants so that they optimize their long-term outcome of these children. Our patients have very vulnerable and rapidly developing brain, and it does matter what we do during this time and what we do not do. There are many known risk factors which damage the brain permanently in preterm infants, and many of these known risk factors are related to their ventilator treatment. They are in risk because of undertreatment, but especially because of overtreatment. As newborn infants, they have compensating mechanisms when they have breathing problems. They compensate with increasing blood flow in their brain. But when they are vigorously resuscitated, overtreated, hyperventilated, the vasculature in the brain constricts, they get ischemia in the brain, and they get developmental problems like cerebral palsy, which was in earlier decades quite frequently, too commonly seen in preterm infants. In our hospital, we have brought the incidence of CP from 10% to 2% in very low birth weight infants by improving the treatment, which means by making the treatment more gentle. And now CP, it is a rare event even in this risk population. The first step to make ventilation support more gentle was to introduce early nasal CPAP to the delivery room, where we started it usually during first 2 minutes of life. And I think that the next significant step to make ventilation respiratory support more gentle is NAVA ventilation. I plan to share with you one patient case. This patient is still in our unit, so I'm talking about her. She's here 4 hours old. No, sorry, she's here for 4 days old when she's at her skin to skin with her mother on NAVA ventilation. She was born at 25 weeks of gestation, so this case is a typical patient in our unit. In other presentations, I have gone through some extreme difficult patients. Now I chose somebody who has quite typical course with typical problems too. She was a B twin, was born after her brother in a breech presentation. And this delivery was unexpected, very rapid, so they got betamethasone only 3 hours prior to the delivery. Mother was GPS positive and was treated with penicillin. She was born very immature. Eyelids were still fused. APGAR scores were 5 and 7, and you can see from these numbers that she was growth retarded. She didn't have spontaneous breathing efforts. She was ventilated with bag and mask for 3 minutes. After that, spontaneous breathing started, and we started early nasal CPAP at 5 minutes. At this point, we transferred our babies to NICU, 7 floors, and we have a practice of elective intubation. So we intubated this baby at 50 minutes of age after propofol sedation and gave surfactant. And after surfactant administration, we started NAVA ventilation. And because of NAVA, we started caffeine, loaded caffeine. Here you see the X-ray after intubation with hazy lungs, which are consistent with RDS. Here you see her NAVA settings, which are typical NAVA settings for our patients. She had very variable breathing efforts. During the first day of life, you can see here that she had very low spontaneous breathing. And here you can see periods of apnea. We used this new version of NAVA with 2-second apnea time. So you can see that this machine compensated. When she didn't breathe, we got this backup ventilation going on. And you can see here on the trends very nicely when she needed backup ventilation, and there were long periods of time when she had sufficient spontaneous breathing and very low backup times despite short apnea time. This is from the second day of life, where you see typical periodic breathing pattern for preterm infants. And here you see regular breathing with a sigh. And initially the care was as planned. At 5 days of age, we could extubate the baby to nasal CPAP. She was normal ventilated during the first week of life. Then she started to have, at 7 days of life, frequent apnea, which is typical for these patients. We have very good breathing effort initially, and for some reason what I do not understand, and I would like to know the answer why they lose that breathing effort. We tried to stimulate her breathing with NIF-NAVA. Didn't succeed. We had to re-intubate this baby at 9 days of age due to apnea. And during the next 4 days, we were alternating between SIMV plus pressure support and NAVA because of the poor breathing effort. At 13 days of life, after 4 days now again on ventilator, we succeeded to switch her to NAVA ventilation, and 3 days later succeeded to extubate, and we did it now to NIF-NAVA. And 2 days later to nasal CPAP. At 1 month of age, she was on high flow nasal cannula, and at 42 days of life off respiratory support. Here they are with their high flow nasal cannulas at 41 days of life. Both this baby girl and her twin brother. And shortly about the brother, he was born from meconium-stained amniotic fluid, was on early nasal CPAP at 5 minutes of age, was intubated in the unit at 30 minutes of age, but he had more breathing problems, more hypercarbia, required high-frequency ventilation at 3 hours of age, and that was continued up to 6 days of age. And we extubated directly from high frequency to CPAP. The same thing happened here. The baby needed re-intubation due to apnea, was on ventilator with alternating modes between SIMV and NAVA. And at 3 weeks of age, this baby was extubated successfully to NIF-NAVA, after 2 days to CPAP, and then at 1 month to high flow nasal cannula. And now he is also without respiratory support. Then I thought to show some slides to demonstrate some typical features of NAVA patients from other preterm patients we have. This is here to demonstrate what happens when we switch to SIMV. And here you can see they are evening hours. You can see a long apnea here in this patient, and a doctor coming in and switching the baby to SIMV. And that is what the typical pressure difference we see. This top peak inspiratory pressure here is 21 water centimeters, and in NAVA it's usually half of that. Here you see their apnea, which was the reason for switching. And when we take a close-up picture, you can see that it was a long period of time without respiratory effort. A lot of backup ventilation there. You could see here that in the morning we came in and we switched back the baby to NAVA, and we can here see that this baby was breathing nicely on NAVA. Nice regular breathing, beautiful, beautiful curve. Can't be nicer. She had apneas, but with a short apnea time, the respirator comes in and compensates those apnea, typical for preterm infants. And this was also with 2-second apnea time, which has worked well with these tiny babies. This slide I took here to demonstrate how useful it is in our everyday work to have all this information in these trend curves. They are rich in information. You can see that during morning rounds here we have had a patient who had very regular breathing, very little backup time here. During daytime something happens, the baby starts to have apnea, and you can very clearly see them here in the trend curve. And then the doctor needs to be there to think if there is infection or baby's tired or what is going on. And I think it's one of the most important teaching points for new NAVA users that they routinely check the trends and analyze their information from there. This is a baby who was born with only 490 grams of birth weight. And you can see that she is successfully on NAVA, breathing nicely. Despite of short apnea time, the backup ventilation is minimum. And this is my last slide. This is another patient who has been in our unit for more than 4 months. And although the bottom line here in the treatment is to optimize the long-term prognosis, it is important what is the quality of the life for this baby during these first 4 months of life too. And the same things that improve the quality of life there in the unit, they improve their long-term prognosis too. Thank you.